Normally, when 10 couples get married, it takes them at least 1 year to achieve pregnancy. At the end of 1 year, out of these 10 couples, 9 achieve pregnancy, and one of them still doesn't become parents. That couple is called an infertile couple. So, if a couple comes to me before 1 year of marriage, I tell them, forget it, just have natural sex around the time of ovulation and try your luck. If they really insist, then I would just do some basic tests, like in the husband I would just do a semen test to find out whether there is anything grossly wrong in the semen, and in the wife I would do generally an ultrasound just to see whether everything is okay, maybe a few hormone tests like a thyroid, prolactin, and a very popular test called anti-Mullerian hormone or AMH test to look at the ovarian reserve. Normally the AMH ranges between 2 to 3.5. So if I see all these things are okay, then I tell them to just have relation sex for 1 year's time, and if they still don't achieve pregnancy, and then I start investigating this couple. So in this, when I start investigating this kind of couple, I do the investigation in the male and in the female. So in the husband, I would do a general semen analysis after 3 days of abstinence and normally look at the count, the motility, the morphology, and if there is any problem, we would examine the husband and treat him with medication. Sometimes, very rarely, you may need some surgery. As far as a woman is concerned, the wife is concerned, we would do her investigation, we do a blood test. Mainly we would look for thyroid problems by doing a T3, T4, TSH. We look at a prolactin level to look, and we'll also look at the anti-Mullerian hormone level, which I've already mentioned to you. And in trying to find out whether there is any major anatomical problem, we would do a ultrasound. Normally we do a 3D ultrasound nowadays to find out if there is any problem in the uterus in the form of fibroids, adenomyosis, malformation, septum, and if there is any problem in the adnexal area in the form of endometriosis or a fibroid in the adnexa or a swollen tube which is called a hydrosalpinx. So if everything is normal, we also look at the tubal patency normally to find out whether the fallopian tubes are open or not. The general test we can do is a X-ray of the womb. It is called a hysterosalpingography, which is a very simple outpatient procedure. You don't need any anesthesia, and if you don't want radiation, nowadays you can do it with a saline. So instead of using a dye and doing an X-ray, you can push a saline into the uterine cavity and look at it under ultrasound. It is not as accurate as a HSG, but it is good enough. If we feel there is any problem in the pelvis, if there is a doubtful HSG, if there is swelling, if there are any fibroids, if there is any other pathology, sometimes under anesthesia we do a endoscopy. So we do a laparoscope, that's a small telescope which we put under anesthesia through the navel. Small incision is made and we keyhole surgery it is known as, and we put the scope into the abdomen to see if there is anything wrong in the uterus, the tubes and the adnexa. At the same time, we also put a scope into the uterine cavity, and that's called a hysteroscope, and see whether there is any abnormality in the cavity. Normally, when we do a laparoscopy, hysteroscopy, we also test for tubal patency, that is whether the tubes are open or not, by pushing a blue colored dye called methylene blue, and if the dye which you push from the vagina inside the uterine cavity, if it comes into the pelvis and you can see it by a laparoscope, you know that the tubes are open. So all this is done simultaneously, and if there is any abnormality or any pathology such as a fibroid, we'll try to remove it by laparoscopy. If there is any hydrosalpinx, we'll treat it. If there is a collection of blood into the ovary called endometriosis, we'll correct it. So nowadays we do a simultaneous diagnostic cum operative endoscopy at the same time. So once we do all this thing, if the woman still doesn't become pregnant, then we go to the next level of IUI, IVF or ICSI. Many of the times when they come to me first time, everything is normal. All the tests are normal. So in these patients, I tell them to have timed intercourse as the first treatment. If timed intercourse fails, then we go for IUI. If that fails, we go for IVF. If that fails, we go for ICSI. However, if there is anything grossly abnormal, then we can't do timed intercourse. We have to go to the next step. We have to do an operative endoscopy and then go straight towards IUI or IVF or ICSI. If the tubes are blocked, we can't even do IUI. We go directly for IVF or ICSI. So this is how, based on the pathology which we encounter in the couple, we can modify our treatment. But in general, the 4 major treatments are timed intercourse, which will help 60 to 70% of patients to achieve pregnancy. If that fails, then intrauterine insemination or IUI, which the normal success rate is around 10 to 15% per attempt. If that fails, we go for IVF, which has a pregnancy rate of around 40%. And in those patients which have a poor male factor like less count or less motility or abnormal morphology, instead of doing IVF, we do ICSI. The full form is intracytoplasmic sperm injection.